नमस्ते बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, Faculty of Homeopathic Science in JAYOTI VIDYAPEETH University. In this series of respiratory disorders, today we will be continuing with pneumonia. Pneumonia is an inflammatory condition of the lungs that is usually caused by infection with bacteria or viruses that are affecting primarily the small air sacs known as the alveoli. Typically, symptoms include some combination of productive or dry cough, chest pain, fever, and troubled breathing. It can be of the following types: community-acquired pneumonia, hospital-acquired pneumonia, suppuration and aspirational pneumonia, and pneumonia in the immunocompromised. So, what is pneumonia? It is an inflammatory condition of the lungs, usually caused by infection with bacteria or viruses, affecting primarily the small air sacs that are known as alveoli. First, community-acquired pneumonia. It occurs in 5 to 11 per 1,000 adults population who suffer from community-acquired pneumonia every year. The incidence varies with age, being much higher in a very young and very old people, in whom the mortality rates are always much higher. They spread by droplet infections. It accounts for almost 1/5 of the childhood deaths worldwide, with approximately 2 million children die under the age of 5 years. The classical pathological response evolves through the phase of congestion, red and gray hepatization, and finally resolution with little or no scarring. Predisposing factors. There are various predisposing factors that are responsible for the development of pneumonia, like cigarette smoking, upper respiratory tract infection, alcohol, corticosteroid therapy, old age, recent influenza infection, pre-existing lung disease, HIV, and indoor air pollution. It is caused by influenza A and influenza B virus, chickenpox respiratory syncytial virus, parainfluenza virus, measles, and adenovirus. The clinical features. It presents as an acute illness in which the systemic features are present, such as fever, rigors, shivering, and vomiting predominate. The appetite is lost and headache. There is breathlessness and cough, which at first is characteristically short, painful, and dry, but later accompanied by expectoration of lipopurulent sputum. The clinical feature includes pleuritic chest pain, which can be a presenting feature and may be referred to shoulder or anterior abdominal wall. The clinical signs reflect the nature of inflammatory response. The majority of the cases of community-acquired pneumonia are due to infection with Streptococcus pneumoniae. Recent infection may predispose to Staphylococcus aureus. Which investigations can be done in the cases of community-acquired pneumonia? Objectives are to exclude other conditions that mimic pneumonia, assess the severity, and to identify the development of complications. A chest X-ray usually provides confirmation of the diagnosis. The common radiological features of pneumonia. There is a dense opacity within the right upper lobe of the lung. There are also air bronchogram lines. There is increase in number of bronchovascular markings. There is some loss of definition of upper right heart border that is called as Silhouette sign. Microbial investigation consists of sputum examination, direct smear by Gram and Zeal Nielsen staining, culture and antimicrobial sensitivity testing. In blood culture, frequently positive in pneumococcal pneumonia, serology, acute and convalescent titers for mycoplasma, chlamydia, Legionella, and viral infections. Pneumococcal antigen detection in serum or urine. Polymerase chain reaction, mycoplasma can be detected from swab of oropharynx, throat or nasopharyngeal swab. It is helpful in children or during influenza epidemic. Differential diagnosis. The various conditions which can resemble community-acquired pneumonia. Pulmonary infarction, pulmonary or pleural tuberculosis, pulmonary edema, pulmonary eosinophilia, malignancy with bronchoalveolar cell carcinoma. In the management, we can administer oxygen therapy, fluid balance, antibiotics with amoxicillin, erythromycin, etc., and treatment of pleural pain. Also physiotherapy. Prevention of community-acquired pneumonia consists of smoking cessation, influenza and pneumococcal vaccination, tackling malnourishment and indoor air pollution, encouraging immunization against measles, pertussis, and Haemophilus influenza type B in children. Next, we start with hospital-acquired pneumonia. A new episode of pneumonia occurring at least 2 days after the admission to the hospital is known as hospital-acquired pneumonia. At-risk people includes older people, the patient in intensive care units, especially when mechanically ventilated, in which case is termed as ventilator-associated pneumonia, or in short, we call it as VA. Healthcare-associated pneumonia, or it is called as HCAP. The development of pneumonia in a person who has spent at least 2 days in hospitals within the last 90 days, attended a hemodialysis unit, or received intravenous antibiotics, or been a resident in the nursing home or other long-term care facility. Etiology consists of the gram-negative bacteria, example, Escherichia coli, Pseudomonas, and Klebsiella species. Staphylococcus aureus, including methicillin-resistant Staphylococcus aureus, or MRSA, and anaerobes. Predisposing factors consist of reduced host defense against bacteria that occurs in corticosteroid treatment, diabetes, and malignancy. Aspiration of nasopharyngeal or gastric secretions, immobility or reduced consciousness level, nasogastric intubation. Bacteria introduced into lower respiratory tract, endotracheal intubation or tracheostomy, infected ventilators, nebulizers, or compressors. Bacteremia consists of abdominal sepsis and intravenous cannula infection. The clinical feature includes any hospitalized or ventilated patient who develops pulmonary sputum or endotracheal secretions, unexplained increase in oxygen requirement, and a core temperature of greater than 38.3 degrees Celsius. The investigation includes a leukocytosis or leukopenia. The investigations are similar to that of the outline for community-acquired pneumonia. The management consists of empirical antibiotic therapy that should be based on local knowledge of pathogens and drug resistance patterns, and variables such as length of the hospital stay, recent antibiotics, and comorbidity. Antibiotic cefoxitin, gentamicin, MRSA is treated with intravenous vancomycin. Physiotherapy in those who are immobile or very old. Adequate oxygen therapy, fluid support, and monitoring is essential. Prevention. Despite appropriate management, the mortality from hospital-acquired pneumonia is approximately 30%. Emphasizing the importance of prevention, good hygiene including both hand washing and equipments. Steps to minimize chances of aspiration and limit the use of stress ulcers. Prophylaxis with proton pump inhibitors and oral antiseptics. That is chlorhexidine 2%. Next, we start with suppurative pneumonia or the aspirational pneumonia. Etiology and clinical features overlap in both the conditions. Suppurative pneumonia is characterized by destruction of lung parenchyma by the inflammatory process. Causative agent consists of streptococcal pneumonia, Staphylococcus aureus, and Streptococcus pyogenes, and Haemophilus influenza. The clinical feature consists of productive cough with large amount of sputum, sometimes fetid and blood stain. There can be pleural pain, high remittent pyrexia, digital clubbing, that is 10 to 14 days. Chest examination usually reveals signs of consolidation. There can be pleural rub and rapid deterioration in general health, marked weight loss. Investigations. The radiological features, homogeneous lobar or segmental opacity, consist with consolidation or collapse. Abscesses are characterized by cavitation and fluid level. The pre-existing emphysematous bulla becomes infected and appears as cavity containing air fluid level. The culture, blood and sputum. Management. Oral treatment with amoxicillin, co-amoxiclav, and oral metronidazole. The surgery if no improvement occurs despite optimal medical therapy. And removal or treatment of any obstructive endobronchial lesion. Next, we start with pneumonia in the immunocompromised patients. Patients immunocompromised by drugs or disease. The causative factors include gram-negative bacteria, especially Pseudomonas aeruginosa, viral agents, fungi, and microbacteria. What are the causes of immune suppression? Defective phagocytic function consists of acute leukemia, Cytotoxic drugs. Effect in cell-mediated immunity consists of immunosuppressive drugs, cytotoxic chemotherapy. Effect in antibody production. Multiple myeloma, chronic lymphocytic leukemia. Clinical features. The clinical feature consists of fever, cough, and breathlessness. The cough and breathlessness can be present several days or weeks. Invasive pulmonary aspergillosis causes fever, pain, pleural pain, or hemoptysis or pleural rout. Invasion of pulmonary vessels causes thrombosis and infarction. The systemic spread may occur to the brain, heart, kidney, and lungs, and other organs. The diagnosis. The invasive investigations such as bronchoscopy, transbronchial biopsy, or surgical lung biopsy are often impractical. Induced sputum for obtaining microbial samples. The management. Broad spectrum antibiotic therapy, antifungal or antiviral therapies may be added. Mechanical ventilation increases the risk of nasopharyngeal pneumonia. Homeopathic management. There are various homeopathic medicines that are having a wonderful result in the cases of pneumonia. Bryonia. Dry and painful cough with dry throat and intense thirst. Worse by least motion and better by absolute rest and heart pressure. Drosera. There is dry cough, worse at night and from the warmth of the bed. Triggered by speaking or laughing, with a feeling of tickling in the throat. Epercel relieves dry, hoarse cough, worsened by cold air and cold drinks, occurring at the beginning and at the end of the night. Ipecacuanha. Dyspnea and constriction with chest, cough incessant and violent, with every breath. Chest seems full of phlegm but does not usually cough. Phosphorus. Hoarseness and tickling cough. Cough can be aggravated by talking, laughing, and exposure to cold air, thirst or cold drinks. Pulsatilla. Wet cough with thick yellowish phlegm aggravated in the throat. Spongia tosta. It relieves cool, barking cough, especially after a chill or cool weather. Worse when lying down at night. In the next topic, we will be discussing about neural effusion. This session was powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention it in the comment box and I will try to resolve. Thank you.